If you're an ICU nurse, you know that titrating noradrenaline is, let's be real, one of the highest risk things we do. So today, we're going to break down a protocol designed to standardize these transitions, making them way safer for our patients.
And this is really the million-dollar question, isn't it? We've all had that heart-in-your-throat moment managing a potent vasopressor, where one tiny change can have a massive impact. This protocol is all about giving us a clear, standardized answer every single time.
So, let's dive into the why behind all this. The goal here is pretty simple. Get everyone on the same page. When we standardize, we create a predictable, safe environment. It's how we prevent those abrupt, really dangerous swings in blood pressure that we all dread.
So what is this protocol exactly? Well, think of it as your roadmap for navigating those tricky moments. It's basically a standardized playbook for adjusting a dose or switching between concentrations, all without causing that scary hemodynamic instability. Okay, first things first, before we can even get to the transitions, we have to be rock solid on how to start and escalate the infusion safely. So we're going to begin with a low-dose preparation. You know, the beauty of this whole process is its simplicity. The rules are crystal clear, no gray areas. You start the low-dose prep at 5 mL an hour, you escalate in these predictable 5 milliliter per hour steps based on the patient's map, and there's a hard stop. The max rate is 20 mL per hour. Super easy to remember and even easier to execute safely.
And here's a really crucial safety net. Let's say you're weaning the patient, you decrease the rate, and their pressure drops. You don't have to guess what to do next. The protocol is super specific. You increase it back to the previous multiple of 5. So if you went from 10 down to 8 and the BP falls, you go right back up to 10. It completely takes the guesswork out of the equation.
Okay, let's move on to our first transition. This is the escalation, moving from that low-dose preparation up to the high-dose one. And as you'll see, this one is designed to be really straightforward. The trigger couldn't be simpler. You hit that 20 mL per hour max rate on the low dose. The action, just as simple. You swap out the syringe. Now, the absolutely crucial point here is that you use the same central line port and the same tubing. You don't break the line, which means there's no risk of an accidental bolus. You just start the new high-dose syringe at 5 mL per hour, and you keep titrating from there. All right, now for the one that requires our full attention. Transitioning down from high dose back to low dose. This is a fundamentally different and much higher risk procedure. This is where meticulous technique is absolutely everything.
This is probably the most critical concept to get. The two transitions are polar opposites, like night and day. Going up is simple. It's just a syringe swap on the same line. But going down from high to low, that's a high-risk procedure. It happens at a very low rate, just 2 milliliters per hour. You need a completely new line, and most importantly, you must aspirate the port. Why? Because that port is full of high-concentration drug. If you don't get it out, you risk giving the patient a massive bolus, causing a dangerous hypertensive crisis.
So let's walk through this high-risk procedure, step by step. First, you stop the high-dose pump. Second, and I'm going to say it again because it's that important, you aspirate that port until it is completely clear. Third, you connect your brand new low-dose syringe and line. Fourth, you restart the infusion at 20 milliliters an hour. And finally, you do not walk away. You observe that patient like a hawk for the next 5 to 10 minutes, watching for any blood pressure changes.
Finally, let's cover the non-negotiables. These are the safety rules that apply at all times, during every infusion, every titration, and every transition. Think of this as your universal checklist for noradrenaline administration. Let's finish with the fundamentals. First, your NORAD line is sacred. It needs a dedicated lumen, period. Never, ever flush it or give a bolus through it. Document every single rate change with the time, map, and the reason. Always verify your line is patent. And finally, labeling isn't optional. Label the hub of the central line itself so there is zero confusion.
This quote right here gets to the heart of a core danger. You just can't stop noradrenaline abruptly. The patient's system adapts to it, and stopping it suddenly can cause a catastrophic crash in their blood pressure. That's rebound hypotension. This is exactly why every single wean and every transition has to be so deliberate and controlled.
So, as we wrap up, I'll leave you with this question to think about. What is the one safety check from this protocol that you will absolutely master on your very next shift? Whether it's aspirating that port, being diligent with your documentation, or crystal clear labeling. Because at the end of the day, consistent, excellent practice is what keeps our patients safe. Thanks for tuning in.